Greetings, Dr. Thay. The following presentation focuses on a practice change for a tertiary high-risk obstetrical service in a tertiary academic medical center where I am employed as a clinical nurse specialist. The objectives for this presentation are to recognize the symptoms, prevalence, and impact of traumatic birth and the occurrence of PTSD. Also, to apply translational research to support changes in practitioner behaviors and skills to improve practitioner efficacy for recognition and response of postpartum PTSD. I'll start with the definition of traumatic birth. Traumatic birth is defined as when the birth event is to be believed by an individual, mother, father, or other witnesses, that the mother's life or her baby's life was in danger or that a serious threat to the mother's and or baby's physical or emotional integrity was compromised. There are three primary influences that are attributed to traumatic birth. These three primary influences are traumatic labor and delivery, and this can be like an emergent cesarean section, shoulder dystocia, postpartum hemorrhage, or any complication of the pregnancy. A prior traumatic birth, such as a previous traumatic birth, or sexual abuse, or neonatal complications. The baby may require resuscitation at birth and needs respiratory support and be transported to the NICU. This data shows the significance of the problem. We have 9% of women giving birth meet the criteria for postpartum PTSD symptoms caused by traumatic birth. In the hospital where I work, our population consists of about 65% Medicaid, underserved women, and like I said earlier, we have a high census of high-risk OB cases. 1 in 5 women have a history of childhood maltreatment. Childhood maltreatment is defined as physical, sexual, or emotional abuse, or physical or emotional neglect. The women have an increased risk of experience a traumatic birth. In fact, there is a 12-fold incident. And we see that postpartum PTSD is often mistaken for postpartum depression, but the data shows 40% of women who develop postpartum depression, it is a result of the PTSD due to birth trauma. The first step will be to conduct a prenatal screening utilizing the Adverse Childhood Events, other known as the ACE survey, to determine the type of childhood maltreatment abuses, whether it's physical, sexual, or emotional, or all three, or just one. A score of 5 or more on the ACE survey has shown to increase the incidence of negative health outcomes. If the woman does screen positive, then the practitioner should conduct a primary care PTSD. This is a 5-item screen that is designed for use in primary care settings. The measure begins with an item designed to assess whether the respondent has had exposure to traumatic events. This also would include the PTSD Checklist 5, which is a 20-item self-report measure, and this total score of 33 or higher suggests the patient may benefit from PTSD treatment. The patient can be offered an evidence-based treatment for PTSD, such as cognitive processing therapy. We'd also want to include integration of the National Center for Trauma-Informed Care. This is a standardized plan of care for the trauma survivor. It utilizes the 3 E's and 4's to determine the severity of the trauma. An example of the application of the 3 E's and the 4 R's for trauma informed care would be first, the event. So we have Susan, who was sexually abused by her stepfather as a young girl and experienced date rape as a young adult. Her experience: Susan told herself she would remain single and avoid sexual activity so she would not have to relive the experience. The effects for Susan was that Susan became involved in a loving relationship but still finds intimate contact difficult and disassociates during intercourse. The effects specific to childbirth: Susan is extremely anxious when a vaginal exam is done and dreads being in labor. So the practitioner can practice the 4 R's for Susan. The practitioner realizes that the vaginal exams may cause flashbacks for Susan. The practitioner recognizes that an adjustment to care must be made to help Susan feel safe and secure. The practitioner responds by referring Susan for trauma-specific therapy, and the practitioner will avoid re-traumatization for Susan by limiting vaginal exams. To determine the evidence for this project, I used the Johns Hopkins Nursing Evidence-Based Practice Levels of Evidence. The articles listed here, I have 2 level 1s, 2 level 3s, and 1 level 4 in my references. Level 1 literature, which is defined as experimental studies with a systematic review of RCTs, is appropriate evidence to support any clinical question. And of course, level 1 is the highest level of evidence. Level 3 literature is defined as non-experimental studies, provides appropriate evidence to support etiology, prevention, and quality improvement. Implementation for clinical practice. We have all staff in service for trauma informed care, and that is to provide a safe and supportive environment for the pregnant women. These next 3 points are particularly important in my service area, as we are an academic medical center and we have a large number of OB and family medicine residents. So these women are exposed to increased obstetrical provider interference in the birth process. It is necessary, but we should always be retreating the woman with respect and dignity, as if she is a sexual abuse survivor. A vaginal exam can be very traumatizing to her. We need to look for early recognition of trauma-related symptoms, such as uncontrolled anxiety, and the literature even shows descent of the baby can be due to psychological factors as opposed to it being something physiological. It's important that prior to the discharge, the woman's asked if she experienced a birth trauma. And if she voices that she did have a traumatic birth, then the post-traumatic stress symptom scale needs to be done. And if she screens positive, then she needs to be referred to mental health interventions. A couple of therapies that are recommended are the cognitive behavioral therapy, and this is where the provider helps the patient learn how to change unhelpful behaviors or thoughts. Cognitive processing therapy teaches the patient to reframe negative thoughts about the trauma. It involves talking with the provider about the patient's negative thoughts and doing short writing assignments. Another therapy is the eye movement desensitization and reprocessing. This helps the patient process and make sense of the trauma. It involves calling the trauma to mind while paying attention to a back and forth movement or sound, like a finger waving side to side, a light, or a tone. And then we need to provide a list of postpartum PTS support services to the client. This concludes my presentation on traumatic birth and PTSD. Thank you.